Hey guys, this is Brian from the Concrete Confessional Addiction and Recovery blog. I'm also known as the Neuromancer and Neuromantic here on YouTube, and today I'm going to talk about opioid maintenance medications. So if this is your first time viewing my content, I am a science teacher and former medical student who has been addicted to opioids and benzos in and out of recovery for the past 15 plus years. Currently tapering off of methadone maintenance, so I've got some real skin in this game, this debate that we're going to talk about today. Um, so I just want to share my own reflections on being on and off these medications for over 12 years now. Now, if you are approaching this and you don't know what opioid maintenance is, there are two medications that are commonly used for this purpose, okay? One is buprenorphine, also known by the trade name of Suboxone, Subsolve, a lot of other trade names. The other is Methadone. And what these are is they're opioid medications, so they stimulate the same receptors and produce a lot of the same effects as fentanyl, heroin, morphine, oxycodone, hydrocodone, those short-acting opioids that a lot of people get addicted to. So they produce similar effects, but they have longer half-lives, meaning that it's possible to stabilize them in a way that it's usually not possible to stabilize on those short-acting opioids. And there's some other chemical properties that they have that make them suitable for this sort of stabilization function that you're using them for in opioid maintenance treatment, which is also called MAT, medication-assisted treatment. So again, the two primary forms of MAT for opioid use disorder are buprenorphine and methadone, and there is an important distinction between the two of them. So buprenorphine is a partial agonist at the mu opioid receptor. That means that yes, it's a strong opioid, but there's a ceiling to its effects. So if you go up to a certain level and then you take more, you're not going to get any more effect, okay? So at that level, it will efficiently block other opioids if you try to take them to get high, but taking more buprenorphine or other opioids isn't going to produce more opioid effect. It's also for that reason, because of that ceiling, it's less dangerous in overdose, and it's less sort of, the side effects tend to be a little bit less prominent than with full agonists. Now, methadone is a full agonist. That means when you increase dose, you're going to get more and more effect the entire way up until you overdose. So there is a distinction with a difference between buprenorphine and methadone, but overall, the general sort of strategy with medication-assisted treatment is you're giving an opioid addict an opioid to stabilize their neurochemistry and to get them shifted toward a healthier way of living. So rather than leaving them feeling like a fish out of water in severe, protracted, acute and post-acute withdrawal for weeks on end in early recovery, you're giving them an opioid to kind of calm their system down. It's a little bit milder than the drug that they would probably be taking to get high, but it's just there to stabilize them and to reduce cravings, and so sort of like make sure that they're a little bit more emotionally consistent and that they can sleep a little bit. That is the theory. Now, because of that, there has also been huge controversy associated with methadone and opioid maintenance through buprenorphine, particularly in the US. So in the late 60s, early 70s, when methadone clinics were opening up for heroin addicts, there was huge community opposition to that in the US. It was very difficult for any potential methadone clinic to even find a location where it could open up, where it was, not in the middle of nowhere, because there was so much opposition to the idea of you're getting drug addicts high. The reason that these medications have become used so widely is because the success rates for treating opioid use disorder and opioid addiction, if you're not using maintenance, are abysmal. They're like single digits, best case scenario. So with these medications, there's no question you tend to stay alive longer, which is good, right? And you also tend to stay away from other illicit substances and other your drugs of choice. You tend to stay away from those at a higher rate than if you're not using opioid maintenance medication. So they work. There is data to prove that, but there are significant issues associated with them. So if you've been around, opioid maintenance for a while, you hear a lot of things like Suboxone took my soul, or methadone killed my creativity, or I felt like a zombie when I was on buprenorphine, and you hear a lot of the same things that people kind of, when they're talking about the older school antidepressants, same same kind of comments, except even worse. You know, you hear people say that they feel like, the way I explain it sometimes is like someone took a dimmer switch and just turned the brightness of my soul down. You know, everything that makes me me, it's kind of a little bit dampened on methadone and buprenorphine. And by the way, I have been on both medications through the years. So again, I've got skin in this debate, and I have seen both sides of the maintenance coin. So yeah, that is kind of the theory of these medications. There's also that perennial question of, are you in recovery? If you're stabilized and taking buprenorphine or methadone, are you considered in recovery? And I'm going to leave that question to address till the very end, because there are some points that I want to make along the way that will be relevant to answering that question from my perspective. So rather than just going through pros and cons, the way that I organized my thoughts was, it's sort of like the best things about these medications can actually be the worst, the most harmful things about these medications. So that's the kind of postmodern approach that I'm taking today when I talk about them. So without further ado, the first thing that can be wonderful about these opioid maintenance medications is that they do stabilize your emotions. So I had a counselor tell me once that a lot of recovery from addiction is about learning how to live in the 4 to 6 out of 10 range instead of the 1 to 9 out of 10 range. There's a lot of truth to that. So these medications can help restore a more normal neurochemistry, and because of that, your emotions aren't so volatile. Your decision making is a little more stable. It's a little bit more like what it would be if you had not had all the brain changes that happen due to addiction happen, to your central nervous system. So that can be a huge boon. It can help with sleep, and because of that, you tend to be just emotionally stabilized by these medications. However, there's a dark side of that, okay? So there was this forum that was run by Dr. Jeffrey Junig, he was a huge advocate of buprenorphine maintenance. He was an opioid addict himself who was in long-term recovery, and he had this forum. If any of you were around the internet recovery community in like the late 2000s, early 2010s, it was called Suboxforum.com. And one of the issues that always came up was, do these maintenance medications kind of zombify you? Like, yes, they stabilize you, but do they like over-stabilize you? Do they sort of like phase you out? And there was this one poster, this really prolific poster, who was a woman who had started buprenorphine for pain management, and she was a really ardent advocate that, no, I am not like dimming myself down when I'm taking buprenorphine every day. Then she tapered off of it, and she said she was sitting with her young daughter playing outside one day. She realized like how much more in the moment she was. She realized how sort of tuned out she had been without even realizing it when she was on this buprenorphine maintenance regimen that she had been on. So, the thing is, those 8s and 9s out of 10, those moments can be what makes life worth living. Those simple pleasures when you're sitting there just enjoying the presence of your young kids, maybe those moments when you've worked towards something and it's paying off in this huge way. Like sometimes you want your neurochemistry to be able to go up to 8 or 9 out of 10. By the same token, well, really the other side of the coin, I would say, is those 1s and 2s out of 10, as much as it sucks to feel them, particularly in early recovery when it feels like the whole world is against you. Your own neurochemistry is against you in early recovery after years of addiction. Your life is probably in a shambles. As much as it sucks to feel those 1s and 2s out of 10, those moments give you the motivation to get better, to actually change and to stay changed. So, that artificial buoying effect of those maintenance medications is not always a good thing. It can be a powerful stabilizer and a pro during early recovery, but it can also hold you back and decrease the motivation to change. So reason 2 is that these medications alleviate opioid withdrawal. So if you've never been through opioid withdrawal, like, you have one huge thing to be grateful for today, because it is atrocious. And it's not just a severe flu. People describe it that way. And physically, yeah, that gets to the heart of the experience. But like mentally, I call it like the Dementor's kiss. It's like all the joy, all the hope and happiness are sucked out of the world. And it just feels so hopeless. And this can last not just for days during acute withdrawal, but for weeks during post-acute withdrawal. And it's not just wonderful that these medications alleviate withdrawal for the subjective benefit of human suffering amelioration, it's also that there is toxicity associated with that opioid withdrawal syndrome. So what happens is when you're chronically taking in exogenous opioids, opioid drugs, for months and years, your body starts ratcheting up these neurotransmitter systems like glutamate, these excitatory, these stimulatory neurotransmitter systems, because it's trying to balance it out, right? You're taking in a big depressant, a downer, and it's trying to balance it out in its own way. So when you remove the downer now, you've got this system, the brakes are taken off and the accelerator pedal is pressed down, and there's actually excitotoxicity associated with that. So there's some damage that happens during opioid withdrawal, and it's part of what makes recovery so difficult, because you're essentially causing brain damage, and then you need to be at the top of your game as far as decision making goes. You're not sleeping, that's part of it. Like that, there's not just a superficial benefit to the relief of withdrawal that these medications give you, is what I'm trying to say, okay? It's actually a substantive benefit that can decrease some of the toxicity related damage that happens during withdrawal, okay? So that is a huge plus, of course, but the problem is you're trading that in, to get that benefit. In the long term, you're dealing with really serious side effects from being on high potency, powerful opioids at high dosages. And make no mistake, when you're on buprenorphine or methadone maintenance, you are taking a dose of an opioid that is many times what you would be taking typically for pain management purposes. So those pain management drugs like hydrocodone, oxycodone, even at low dosages, they have serious side effects like sedation, cognitive impairment. They make you very, very tired, but they destroy your REM sleep, so you're not getting restful sleep. They can cause depression. They can cause loss of libido. These are serious even at low dosages, and at high maintenance dosages, they become incredibly serious. Some of the people I've known on methadone, like their memories are totally shot, and when they taper off the methadone, that goes away. So it is the methadone causing that, or at least contributing to that in a significant way. So the thing is, again, you're getting these serious set of side effects when you're on these opioid maintenance medications long term. The other thing is that because you're not getting any break from the dry mouth, for example, which is a serious side effects of these opioids, you tend to get awful tooth decay. So there was a multi-district litigation, kind of like a class action lawsuit against the manufacturer of Suboxone because of the tooth decay that it was causing in a whole, huge subset of patients. I think that they were successful. I'm not sure what stage they're at in that process, but buprenorphine, and to an even larger extent methadone, they accelerate tooth decay like you wouldn't believe, because saliva has compounds in it that protect against bacteria. So when you're not producing saliva because your mouth is dry 24/7, you are not going to be fighting off the bacteria that cause cavities and dental problems to the extent that you would be normally. And this is much more prevalent of an effect than it is with those short-acting opioids, because you don't get any break from it, because the long half-life means that effect is essentially 24/7. So you've got memory problems, sedation, you've got sleep troubles, being too sleepy and at the same time not getting restful sleep. Loss of libido on both buprenorphine and methadone maintenance is huge for men and women, but especially for men. You've also got serious tooth decay, which is much more potent, again, than what you would get with pain management opioids on pain management doses. Okay, so those are some really serious side effects that you're trading for the benefit of not having to go through withdrawal, or at least not having to go through withdrawal now, because of course, if you want to get off of these medications, they've got their own protracted, really tough withdrawal syndromes to go through. So that's another thing to weigh when you're thinking about this is, can I deal with these long-term side effects? And even some of the side effects that sound kind of not so bad, like constipation, like, yeah, you can take medications to help you go to the bathroom normally when you're on these opioid maintenance medications. However, they're not perfect, and you can get intestinal blockages. In the worst case scenario, people have had to get colostomies because they've had obstructive problems from being so backed up from these medications, and they've had to actually had their GI system rerouted. Like, it can get pretty severe. So your physical and mental functioning is long term going to be seriously impacted by these medications. I know a lot of people like to tell themselves, I'm normal, I'm just who I would be without these medications when they're on maintenance, because they want to feel like they're fully in recovery. And it's just not true. You're on a powerful opioid. You might not feel how different you are from your normal self because you're stable at that altered, state of consciousness and state of being. However, you're very, very, very different from your baseline self, and I would argue it's even more of a problem if you're losing sight of that and you're not aware of it any longer. So, all right, reason 2 is they alleviate withdrawal, but they come with some really serious long-term side effects that are not trivial. Okay, so reason 3 is these medications can be really, really helpful because they kind of put you in remission from your addiction. In the best case scenario, again, Dr. Jeffrey Junig, who ran the Suboxforum.com forum, he used to say that buprenorphine was a miracle medication, that when he went through opioid withdrawal, when he was an addicted anesthesiologist addicted to fentanyl, it was atrocious. So few people made it through early recovery. And he said when buprenorphine came along, he could give in his office, he would give a patient an opioid withdrawal, buprenorphine, and he would see them go back to normal. They wouldn't be high, they wouldn't be super impaired, they would just be like a normal person again, not in the severe, awful opioid withdrawal, not feeling like a fish out of water because their system is so used to opioids and now they can't take them anymore. So he would use the phrase in remission, which in a lot of ways I think was kind of not the best language to use, but I have seen that and I have felt that too. After bad periods of addiction, taking Suboxone for the first week, you feel like normal. You feel stabilized and you don't feel atrocious, However, as I said above, you're not really normal, okay? And the thing is, even if you feel that way, that sort of pink cloud only lasts for, in my experience, like 6 to 12 months, maximum of 18 months. And then your addicted brain does what addicted brains do. It gets sick of being here all the time. It wants to go up here. Now, maybe you relapse once or twice, and maybe it gives you some opioid effect, and you feel propitiated, your addiction is, satisfied, but maybe not. And in that case, I've seen people turn to coke, to meth, to benzos, to anything else they can use to get high. Some people turn to compulsive gambling and sexual behaviors. Like, you're kind of in purgatory because you get some of the effects you want, but because you're stabilized at a relatively low level, you're not really satisfying your addiction. And so it can kind of keep you in that, I call it purgatory. You're in the middle. You can't get what you want, to get high, and you're also not getting all the benefits of being in full recovery, being off of everything, feeling that surge of vitality and not having to be chained to a medication anymore, that freedom. So, it is helpful that you get this kind of remission-like state for a few months for some people, but that wears off. And when that wears off, the problem is that, one way to say this is drugs are the solution, not the problem for most addicts most of the time. We have depression, anxiety, we have maybe unresolved trauma, we have relationship difficulties, we have a whole set of character defects and a way of dealing with the world that is not fair and that is not in our advantage and that hurts the people around us, right? We need to solve those issues in recovery. If we don't solve those issues, we're not going to have a good life. And the problem with suddenly having your neurochemistry restored to quote unquote normal, again, is that it takes away the impetus to change those things that need to be changed. Kind of like, if you're in early recovery without maintenance, and I've been in that situation, you feel so displaced and there's so much discomfort. If you're in treatment, you're really, in my experience, if you're motivated, you're really hanging on to every new skill you learned, every story you heard shared, you're hanging on to that for dear life because you really feel like, I'm not going to make this unless I get some new behaviors, unless I get some new skills, and because maintenance gives you that artificial buoying effect, it can really take away from the desire to do the really hard work to change the things that you need to change to be a better person and a more stable person. So in 12-step programs, and I have another video about why even though I participated in 12-step programs extensively, I don't really recommend them anymore. But in 12-step programs, there's this phrase, easier, softer way. They always warn against the easier, softer way out of addiction. And when I hear that phrase in conjunction with opioid addiction, I always think about maintenance. Like, it seems like such a perfect solution. It's so much more palatable and so much easier to accept than getting off of opioids completely. But in the end, a lot of the benefits fade, and they come with a lot of cons that end up looking, for a lot of people, most, maybe even almost everyone, they end up looking like chemical chains or chemical handcuffs. So you do got to be careful of the easier, softer way, and you got to be aware of, am I using this medication to do the work, or am I taking this medication and I'm sort of using it as leverage to do the work that I need to do on my underlying mental health problems, on my relationships, on my spiritual health, on my values and work and sort of path through life. So again, the very things that make methadone and buprenorphine maintenance useful can, on different timescales and for different people, also make them harmful. So when I think about these things, it's all kind of mixed up these days. And to answer that age-old, very contentious question of, if you're on maintenance, are you in recovery? My personal feeling is you can be. It depends on mindset. If you're on maintenance and that's all you're doing is taking this medication as sort of a glorified harm reduction, if you're allowing it to do all the work and you're just kind of living your life without changing anything other than taking that medication and stopping, your drugs of choice, in my way of thinking about things, you're essentially, like, again, you're using very effective harm reduction, which is great. It's better than addiction, but it is not recovery. But if you're taking that opioid maintenance medication and you are, doing counseling to work on your underlying mental health issues, your anxiety, your depression, if you are reaching out to community, you're becoming involved in smart recovery or 12-step meetings or some other group that allows you to connect with people and get healthier relationships in your life. If you're doing the work, recovery is not black or white, and you can absolutely be in recovery on these medications. Now, will you want to stay on them forever? In that second case, probably not. Probably over a long time, maybe 6 months to a year, you'll taper off of them because you won't need them in the long term if you're doing the work. And when you don't need them, the side effects don't become worth it any longer. So yes, in my opinion, you can absolutely be in recovery on opioid maintenance medications. However, it depends on your mindset. So the way that I think these medications are being used these days is like the end-all be-all. Doctors prescribe these medications and they're like, you're good. Even at the methadone clinic that I'm at, very few people are getting meaningful counseling. Very few people are doing meaningful recovery work outside of taking that medication every day. And because of that, over the long term, almost everybody, like 90% plus, relapse on a yearly basis or even a monthly or weekly basis. So you've really, you got to consider in your own scenario, what am I using this medication for? And I think these medications are phenomenal as a bridge so that you're not going through the extreme physical and mental shock of cold turkey opioid detox over the course of like a week, say, in a treatment program. You can sort of like spread that agony out over a few weeks to a few months so that the withdrawal process is much more manageable. But in my opinion, for like 90+% of opioid addicts, that's how maintenance should be used. It should be a stepping stone, not an endpoint. So in my opinion, if you're a doctor who is just indefinitely prescribing these medications without considering what you can do to get your patient off of them, you're kind of doing them a disservice. Because guys, when you finally get off of everything, if you've been an addict for a long time and you've felt the freedom of not needing any medication anymore, of just being your sort of whole, bright, unfiltered self, like, that is one of the best, most spiritually fulfilling sensations that you can ever have. Like, I can't even put into words how freeing and beautiful that can be. So I don't want to encourage anyone who still needs maintenance for craving reduction and is kind of a support in their recovery to get off of it, because I've known people to do that and to overdose and die. But if you're ready and if you do it slowly enough, I would encourage anyone who's been on these medications for a long time to at least talk to their provider and consider trying to taper off and seeing how things shake down without it. So I think that those are the main points I wanted to cover. I have been around this debate for, again, well over a decade, and I still love I hear new points every time it's brought up. I hear stories that bring to light different facets of this whole discussion. So if you've got anything to weigh in on, please weigh in on it in the comments below. If you've got any questions, I'll be happy to answer them. And other than that, thank you all for listening, and I will see you next time.